And today we're going to be talking about the cephalic phase of integrated response to a meal. Okay, so we have three phases that goes in the body when we eat our food to get fully digested. So what are they? The cephalic phase, the gastric phase, and the intestinal phase. The cephalic phase, from its name, it's what happens mostly in our head. So let's say it's when we smell the food, when we see the food, or when we think about food. So its main purpose is to prepare the GI tract for food. So it's when your body anticipates food, which is a good thing, because when your body anticipates food, it can prepare itself for digestion in anticipation of food when it comes. So it stimulates salivary and gastric secretions mainly, and to a smaller degree, pancreatic secretions. In gastric phase, from its name also, it's what happens in the stomach. So the gastric juice secretion happens in the gastric phase, and it's initiated when food bolus gets into the stomach. Basically, food bolus is the chewed food. Intestinal phase, it's what happens in the intestines. The pancreatic juice secretion happens, bile excretion happens, and digestion and absorption in the small intestine. And it's initiated when food chyme is propelled from the stomach to the intestines. Food chyme is basically the partially digested food in the stomach. So today our focus is going to be mainly cephalic phase and salivary excretion and all that. So the role of the nervous system control in the GI tract, it decreases from oral to aboral end, while the hormonal control increases from oral towards the aboral end. So for example, in the cephalic phase, it's mainly more controlled from the nervous system more than the hormonal control. And gastric is kind of mixed, and then the intestinal is controlled more by hormonal control rather than nervous control. So conditioned versus unconditioned response. Basically, we have something called conditioned reflex and unconditioned reflex. Conditioned reflex, from its name, it's something we learned or we acquired. So it's a learned or acquired response. Unconditioned response is the automatic or innate response. So it's basically we were born with this. Our body knows how to do this without learning it from our environment, let's say. So basically, there was a scientist who did this experiment on a dog where he presented the dog, the meat to the dog, and the dog started to salivate. So this is the unconditioned response because this is normal, this is the inborn reflex, and we were born with that. And then he tried to do something. He tried to present a certain stimulus before giving the meal. And it was about like a stimulus was given and then 2 minutes max, and then the meal is given. More than 2 minutes, it would make the dog not really associate the food with the sound or any other stimulus. So basically, when the scientist gave this stimulus to the dog, whether it was a sound or the sound of a bell or a flashlight, and then presented the dog with the food, the dog, time after time, started to associate this sound and this stimulus with food. So basically, whenever he heard the sound of a bell or saw the flash of a light, he basically directly started to salivate even when meat wasn't presented to him, because in his brain, it was associated that the sound of a bell means food. So this is the conditioned response. When something like sound, or when it's auditory or olfactory stimuli is associated with food. So let's see here. Here there's the sight of food, the sound of food, or the smell of food. Or it doesn't have to be food, but anything that we in our brains connected as food or related to food. Like as I said in the experiment, the dog associated the sound of the bell to food. Basically, for us humans, we associate the sound of a microwave or the sound of the utensils. This is all, for us, it's associated with food. So this is a conditioned response, and this can basically cause our brain to send signals to the cortex and then to the medulla oblongata. And in the medulla oblongata, which is in the brainstem, there's something called the superior and inferior salivatory nuclei. From the superior and inferior salivatory nuclei, cranial nerve 7 and 9 go to supply the salivatory glands and start saliva secretion. And this is basically what happens in conditioned reflexes. For unconditioned reflexes, basically it doesn't have to cross the cortex like the conditioned reflexes. It's enough for the unconditioned reflexes to directly go to the medulla oblongata. With time, when the stimulus is a first time thing, then the signal goes to the cortex. But with time, as the conditioned reflex becomes associated in our brain with food and it's related to food, and we directly know this is something that has to do with food, then it doesn't need to cross the cortex. It will directly go to the unconditioned reflex center in the medullary oblongata, superior and inferior salivatory nuclei. As I said, cranial 7, 9 go to supply the salivatory glands and start saliva secretion. So the structure of the salivary glands, there are two main portions, the acinus and the salivary ducts. As you can see, these kind of circular structures are the acinus, and these are the ducts. So the acinus opens into something called the intercalated duct, and then the intercalated duct opens into something called the striated duct, and then the striated duct opens into something called the excretory duct. So basically the types of cells in glands, we have serous cells and mucus cells. Serous cells are the cells that secrete water, ions, and enzymes. Mucus cells are the cells that produce mucin, and mucin helps in the moisture of the saliva, let's say. Secretion mechanism, the acinar fluid comes from the blood. So it's very close to the osmolarity of the plasma. It's basically isoosmotic. And then this acinar fluid, which came from the plasma of the blood, moves through the intercalated ducts, striated ducts, and finally reaches the excretory ducts. And while it's moving in the ducts, the ductal cells modify this saliva by altering its ionic composition. Okay, so the primary saliva is formed in the acini. This is the primary saliva, which is basically has the same osmolarity of plasma in our blood. But then as it moves through the ducts, it gets modified, its ionic composition is altered, and it doesn't have the same osmolarity of the plasma anymore. The myoepithelial cells here, as you can see the white cells, they are found on top of the acini and the intercalated ducts. And when they constrict, they kind of, you can say, squeeze the duct so the saliva can be excreted. Types of salivary glands, we have the parotid glands, the submandibular glands, and the sublingual glands. The sublingual glands are under the tongue, the submandibular are at the end of the jaw, and the parotid glands are close to the ears. Parotid glands are composed only of serous cells that secrete aqueous fluid, which is water, ions, and enzymes. So parotid, only serous. Submandibular is mixed, and sublingual is also mixed. But the difference is that the submandibular is mainly composed of mucus cells, while sublingual has both serous and mucus cells equally. So the stages of salivary secretion. We have two stages. A stage that happens in the acini, and the second stage happens in the salivary duct. In the acini, we have the primary secretion that is similar to plasma, as I said, and it's isotonic and it has the same electrolyte composition as the extracellular fluid. Salivary duct, it's where this primary saliva gets modified as it passes through the duct. So as you can see here, this is the acinar cells. When the blood crosses the acinar cells, the plasma of the blood crosses the acinar cells, it's isotonic here. It's still the same as the blood in electrolyte composition. But as it moves through the duct, it will get modified and it will become hypotonic. So that's why the final saliva has low Na, low chloride, and high potassium, high bicarbonate, and it's hypotonic. Hypotonicity is due to the reabsorption of NaCl and the impermeability of the duct to H2O. We'll talk more about this when we get into more details. The pH of the saliva is between 6 and 7, so it is slightly acidic or can be neutral. Basically here, we have the ion transport in the acinar cells and the ion transport in the excretory duct. Let's start with the acinar cells. In the acinar cells, we have the sodium-potassium pump. The sodium-potassium pump is what creates the gradient. The gradient that helps the Na2 chloride potassium pump to work, because as you can see, when the Na leaves the acinar cell and the potassium enters, this will pave the way for more Na to enter because Na is leaving. So now the cell reacts by bringing in more Na, like in this channel, the Na2 chloride and potassium pump. And basically, the primary active transport is the active excretion of chloride. So here, when chloride is absorbed into the cell, it goes out and secreted with bicarbonate. When chloride leaves into the lumen of the acinus, Na follows. Why? Because the chloride is negative, and you know, sodium is positive. So to kind of balance this, the Na follows the negative ion, which is chloride. So that's why the primary active transport is the excretion of chloride, not sodium, because sodium only follows chloride. What we're actually actively excreting is the chloride. And then Na follows, and what follows sodium is always water. This is very important to know that water always follows sodium. And then as the water follows sodium, the saliva becomes isotonic. And that's why the saliva is similar in ionic composition to the plasma. Now in the excretory duct, we have the sodium and chloride, the sodium and chloride are reabsorbed here, and the potassium and bicarbonate are secreted. The potassium and the bicarbonate are secreted, as you can see, the potassium and the bicarbonate, and then the chloride and the Na are reabsorbed. This is very important to know. So when the saliva is secreted, it is hypotonic. Why? Because in the duct, what's different from the SNR cells is that in the duct, it's impermeable to water. So even if Na goes out, which doesn't even happen, I'm just saying, even if Na goes out, water can't even follow because it's impermeable to water. But Na either ways gets reabsorbed. So that's why it's hypotonic, because water can't follow. So it's not as, let's say, isotonic as plasma anymore. It becomes hypotonic. Now for the effect of flow rate on ionic composition of saliva. Here, as you can see, here we have the flow of saliva and the concentration of the ions. The faster the flow becomes, the more sodium will have. Why? Because the more no, wait, I'll explain from the beginning. The slower the process of saliva flow, the more sodium would be reabsorbed. Why? Because when the flow of saliva in the ducts is slower, it's going to take its time, it's not rushing, so more sodium is going to be reabsorbed. This allows it to have more time for sodium to be reabsorbed because saliva is moving slowly, so it would remain in the duct longer. So this would make more sodium to be reabsorbed. But if the saliva flow rate increases, the more sodium is going to be left behind because it's moving quickly, so it's not even having time to reabsorb everything. So the more sodium is going to be left behind in the saliva. So basically, a slow flow rate, more sodium, high flow rate, less sodium, because more sodium is reabsorbed back into the acinus, leaving behind the saliva. A high flow rate saliva becomes close to sodium ionic content and close to the tonicity of plasma, so it becomes almost isotonic to plasma. But at low rates of saliva flow, which is the normal rate of saliva flow. So normally, us humans, we have slow saliva rate, a slow flow of saliva, which is normal for us. And that's why saliva is hypotonic, because more sodium is reabsorbed. So we're left with less sodium in the saliva, which makes our saliva hypotonic. The function of saliva, it has several functions. Initial starch digestion and initial triglyceride digestion. Basically, we all maybe thought before that digestion starts in the stomach when we chew the food and swallow it. But actually, the digestion begins in the saliva. And that's why when we're hungry, we quickly reach for sugar because sugar can be broken down in our saliva and can be absorbed by our body. So that's like a quick form of energy for us. So the starch digestion is by the salivary enzyme alpha amylase, and the triglyceride digestion is by the enzyme lingual lipase. Saliva also helps in the lubrication of ingested food by mucus, so it can pass easily through the esophagus during swallowing, and it protects the mouth and the esophagus by the dilution and buffering of ingested food. Helps in articulation and speech, so our speech can be better and properly articulated. There's a bacterial agent in saliva, which is lysosome, which also destroys destroys microbes. And in newborns, it's important because it can seal the mouth cavity during the breastfeeding. So the role of saliva in chemical digestion, as we mentioned, alpha amylase in the oral cavity, it starts the digestion of the starch, basically carbohydrates, glycogen. It's not that effective. It has a really short duration. We can say its effect is minimal. And in the stomach, it only remains active for 15 to 30 minutes. But it mostly is active in the oral cavity. But it's also minimal. But in the stomach, only it remains for 15 to 30 minutes. Lingual lipase, as we said, it hydrolyzes the triglycerides containing long-chain fatty acids in the oral cavity. Also, it has a minimal effect, and this is due to the pH. pH in the oral cavity is not optimal for the lingual lipase to work, but in the stomach, there is optimal pH, so it can actually work better in the stomach. Now, for the regulation of secretion, as we said, we have the conditioned and unconditioned reflexes. And as I told you before, the neural regulation is more important than the humoral in the cephalic phase. As we go down to the gastric phase and the intestinal phase, the neural regulation becomes less and humoral becomes more. So we have receptors, taste receptors, smell receptors, auditory, visual, periodontal mechanoreceptors. Periodontal mechanoreceptors, basically, they're mechanoreceptors in your mouth which can detect forces. So as you're chewing, it can detect the forces of the chewing. Proprioceptors are in the joints and in the mastication muscles, basically the buccal muscles, which detect the active chewing of the food. So these are all receptors that send signals by the afferent neurons to the higher brain centers. As I said, the superior and inferior salivary nuclei of the brainstem, which is in the medulla oblongata, and then this sends the T1 to T3, and sometimes also C8, preganglionic sympathetic fibers, and it also sends preganglionic parasympathetic fibers. So both parasympathetic and sympathetic. The preganglionic parasympathetic fibers are the chorda tympani and the glossopharyngeal nerve. And these are the efferent neurons. And then the T1 to T3 preganglionic sympathetic fibers reach the ganglia, the superior cervical ganglia, and then the postganglionic sympathetic fibers is what leaves the ganglia. And then for the parasympathetic fibers, we have the otic and submandibular ganglia, which also has postganglionic parasympathetic fibers leaving this ganglia. This is all purely memorization. So honestly, يعني الله يعينكم. Humoral control, we have the aldosterone. As I said, it's more neural control. But when it comes to humoral control, in people with hyperaldosteronism, they would have low concentration of sodium in saliva and high potassium concentration in saliva. Why is that? Because aldosterone has the effect of lowering the salivary sodium and increasing the potassium in the saliva. Atropine is a drug. Fear, sleep, dehydration, all they contribute to the lessening of the secretion of saliva. The regulation of secretion, so this is the parasympathetic and the sympathetic again. The parasympathetic, we have the conditioning, as I said, the sounds, the visuals, whatever it is. The food, the nausea, the smell, all they activate the parasympathetic, and we have the dehydration, fear, sleep. They lessen the activation of the parasympathetic. So through acetylcholine to the M receptors, they release saliva, and sympathetic activation through the norepinephrine via the B receptors, they also release saliva. Basically, when someone feels like vomiting, um, don't you feel like if you ever felt nauseous or you were about to vomit, you can feel your saliva being overly excreted, and that's basically helpful for us because if someone is gonna vomit, then they're gonna have all the acidic content in their stomach leaving their body. So the acidic content would pass through the esophagus and the mouth, which can harm the teeth in the oral cavity because of the acidic content. So that's why our body reacts by um, secreting more saliva so that it can protect our teeth. So here we have the salivary secretion effects of the autonomic nervous system, the sympathetic nervous system, and we have the parasympathetic nervous system, as we talked about. What's important, this is very important to know, you need to know that the sympathetic nervous system secretes small amount of viscous saliva with high concentration of organic molecules, basically rich in enzymes, but a small amount of viscous saliva. In the parasympathetic activation, we have secretion of large amounts. The distinction between small and large amounts in sympathetic and parasympathetic is important. So basically, parasympathetic secretes large amounts of serous saliva. Here it's serous saliva, but in the sympathetic, it's viscous saliva. In the sympathetic, it's rich in enzymes. In the parasympathetic, it's not rich in enzymes. What you need to know is that the sympathetic and parasympathetic nervous system, they don't have opposite effects on salivary secretion. On the contrary, they're actually helping each other and they act together to secrete saliva. But the parasympathetic nervous system is predominant. So the physiological tone is created by parasympathetic nervous system normally. So it maintains a certain level of saliva secretion. So what's the predominant physiological tone of salivary secretion? Parasympathetic nervous system. But in case of hyperstimulation of sympathetic nervous system, which can happen in fight or flight response, like fear, the secretion decreases because the sympathetic nervous system would constrict the vessels, which happens under the sympathetic activation. As we know, sympathetic nervous system causes vessels to constrict. So when the vessels constrict, less saliva will be secreted because initially plasma is coming into the SNR cells from the blood. So if these vessels were constricted, less plasma would come into the SNR cells from the blood. So we will not have much fluid there. So the saliva isn't secreted as much in fear or whatever stimulus that causes the sympathetic activation to override. The myoepithelial cells, they are found on the SNR cells and the ducts, as we explained before. And the smooth muscle cells, they are smooth muscle cells. The myoepithelial cells are smooth muscle cells. So if they're smooth muscle cells, they are affected by the parasympathetic nervous system. So they're constricted under the parasympathetic nervous system influence. So this will help in excretion of larger volumes. As I told you, you can imagine when the myoepithelial cells are constricted, they squeeze the gland, they squeeze the acinar cells, they squeeze the ducts, which excretes larger volumes of saliva. Okay. The use of saliva in clinical evaluation, we basically can measure the level of certain hormones in the saliva. So we can take the saliva of a certain person and we can test it and look for the level of certain hormones like cortisol or like progesterone, testosterone. So saliva is pretty helpful when it comes to measuring the level of these hormones. Also, as you all know, we've all experienced PCR during the COVID-19 times. So yeah, when they do PCR, so they can detect if there's any viral infections, and the bacterial infections also can be detected. And saliva is also used to monitor the level of drugs. We have something called xerostomia and drooling. Xerostomia basically means dry mouth. Drooling means constant production of saliva. So they're kind of opposites of each other. The causes of xerostomia, it can be drug related. So someone can be taking a certain drug that has a side effect of causing a dry mouth. A radiation treatment, basically someone with let's say someone has cancer and they undergo radiation treatment. This can like decrease the size of the gland, so it becomes the salivary gland, so it becomes less functional. So this will cause less saliva secretion, so basically cause xerostomia, which is dry mouth. And autoimmune diseases can cause dry mouth as well. For drooling, we said it's constant production of saliva. Treatment of drooling is anticholinergics. And why is that so? Because, as we said here, you can see, here we have the parasympathetic system releasing acetylcholine, which acts on the M receptor. Now, this, as we explained, causes increasing of saliva excretion. What if we, let's say, block this receptor using a drug like atropine, for example? What will happen? Less saliva will be excreted. And that's why, as we said, dry mouth, which is xerostomia, can be drug related, because if someone is taking a drug like atropine, atropine will block the M receptor, which will cause less secretion of saliva. Now, what if someone is taking an anticholinergic? Anticholinergic, from its name, it's something that that blocks the M receptor, the M choline receptor, just like atropine. And this, like as we said, atropine can be a reason for xerostomia, but also any drug that has the same mechanism as atropine can be used to actually treat drooling. So you can say they're kind of opposites in treatment, even in symptoms. What treats this can be the cause of this, if you get what I mean. Also, another treatment for drooling can be surgical removal of the sublingual glands. If a person has an overproduction of saliva, then surgical removal can be a good option. The clinical window between drooling and xerostomia is very small. This sentence means that whenever we're treating xerostomia, we need to be very careful not to cause drooling while treating xerostomia. And the opposite is true. When we're treating drooling, we need to be very careful that this treatment won't cause xerostomia because the clinical window between these two is very narrow. So, like, this can become the other quickly. So we need to be careful. Saliva secretion in cystic fibrosis. In cystic fibrosis, we have a channel called CFTR, which is a chloride channel. In patients with cystic fibrosis, this channel is defective. So when this channel is defective, there's an impairment in the chloride leaving the cell. As you can see, here is the CFTR, and then when there's an impairment here, chloride can't leave anymore. When chloride can't leave anymore, this will cause high Na and high calcium and high proteins in the saliva. So the saliva becomes very viscous because absorption of sodium and water can't happen anymore in patients with cystic fibrosis. And they can also experience other symptoms in their bronchial tree or in the pancreatic juice or in sweat. So patients with cystic fibrosis have very salty sweat. This can be like a clinical presentation for cystic fibrosis. And yeah, we're done with today's session. Does anyone have any questions? I have my number put here, so you can text me about any question you have. And
I'm sorry, but can you re-explain the last slide again?
Yeah, sure. So cystic fibrosis is an impairment in the chloride channel. So this is the chloride channel. So when chloride can't leave the cell anymore, what happens is Na and water can't be reabsorbed. So this makes the salivary Na and calcium and proteins elevated. So saliva will have more sodium and it will be more viscous because sodium and water can't be reabsorbed because the chloride channel is blocked here or impaired. Do you get it?
Yes, thank you.
Or should I? Okay. Great. Can you please scan the QR code?